Bismillahirrahmanirrahim. I'm highly thankful to the organizers of this 6th PSIM conference for inviting me. Today I'll be talking on significant approaches on management of diabetes by triple combination therapy. We all know about the prevalence of diabetes, that diabetes is becoming one of the largest medical problems that this world is facing today. And globally, the recent prevalence of diabetes, which was given by IDF, states that globally almost 589 million people are suffering from diabetes in adult populations, and it makes almost a prevalence of 11.1% globally. And interestingly, almost half of them are still undiagnosed, and they do not know that they are suffering from diabetes, and ultimately they'll be facing lots of complications related to diabetes and its comorbid conditions. If we talk about the economic impact that this diabetes is creating on the world population, it is said that the amount goes beyond 1 trillion US dollars, and almost it is counting 12% of the global health expenditure that is being used throughout the world. And we all know that diabetes is not a single disease that is coming in patients. It is coming with other comorbid conditions like stroke, cardiovascular disease, obesity, MASLD, and many more other complications. If we look at the recent publications by IDF in 2025 about the prevalence of diabetes, globally there are, as I said, 588 million people suffering from diabetes today, and which is expected to increase by 45% by the year 2050. Now, internationally, there are 7 groups of regions which are divided by IDF, and Pakistan lies in MENA group, which is one of the largest growing regions in the entire world. Presently, there are 84.7 million people in our region, which is going to increase, almost it's going to be double in prevalence by the year 2050. Now, the current situation of Pakistan is not good in terms of diabetes. Currently, we are at number 4 with almost 34.5 million people suffering from diabetes. But this number is going to increase by year 2050, and we are going to jump to number 3 position. But as far as the prevalence of diabetes is concerned, we are still number 1. And there is no other country in the world which is matching us in terms of prevalence of diabetes. We are the only country in the world who have more than 30% prevalence of diabetes in our adult population. We are having a prevalence of 31.4%, and this prevalence is going to increase by the year 2050 and is going to be 34.2%. Now, interestingly, diabetes is not nowadays only a simple name of glycemia. Diabetes comes as a combo. It comes with lots of complications related to obesity, complications related to its other risk factors like hypertension, dyslipidemias, and especially the point of time is that we should talk about the cardiovascular risk, because cardiovascular mortality is the number 1 cause of death in the patients of diabetes, and it is not hyperglycemia that is killing, it is the cardiovascular risk that is killing the patients. And also chronic kidney disease, retinopathy, neuropathy, and as we discussed about MASLD, these are all common risk factors affecting the life of diabetic patients. The guidelines previously used to concentrate mainly on glycemia control, but now the scenario is changing. There are lots of research studies that are mainly focusing on cardiovascular risk in patients of diabetes. So now, apart from lifestyle modifications and diabetes education, there are 4 main pillars in the management of diabetes. One of them is glycemic control. The others are blood pressure management, lipid management, and agents which are focusing mainly on cardiovascular and renal protection. If we have a look on the recent guidelines by different societies related to diabetes management, American Diabetes Association says that after lifestyle modification and diabetes education, we must concentrate and we must identify patients who have atherosclerotic cardiovascular risk factors, especially risk of coronary vascular disease, especially risk of heart failure, or any involvement of chronic kidney disease. If there is any involvement of atherosclerotic cardiovascular disease, then the drug of choice is either GLP-1 or SGLT2 inhibitors. If there is heart failure, then the drug of choice is or is SGLT2 inhibitors. And if there is any kidney involvement, then apart from AC inhibitors, we must also start giving SGLT2 inhibitors if the GFR permits. And the other parameters that we look for the treatment is obesity or weight. And in this terms, GLP-1s and SGLT2 inhibitors are the drugs of choice. And as far as the glycemic control is concerned, there are lots of drugs which have potency, which are highly potent in controlling the glycemia, like insulin, like GLP-1s. And apart from them, DPP-4 inhibitors and SGLT2 inhibitors are the drugs which have got very good effects in terms of glycemia control. IDF recently in 2025 had divided the management of diabetes in two broad categories. One is optimal care and the other one is basic care. What do we mean by optimal care is that it is the highest standard of care which is applicable in resource-rich countries. While basic care is the minimal standard care that should be given to every diabetic patient, and especially it is a basic standard in resource-poor countries like our country. Now, IDF guidelines, they are saying that at the diagnosis, when you diagnose new patient without any complications, then apart from lifestyle modifications, metformin should be the standard practice. It should be the first line of treatment. And if the glycemia is high, like HbA1c levels are more than 8 or more than 9%, then combination therapy should be started from the very start of management. And if the patient is having any kind of complications like cardiovascular complications or renal complications, then again after lifestyle modifications, metformin and SGLT inhibitors or GLP-1s should be the first line management. But if the patient is already on treatment and is known case of diabetes mellitus and his glycemia is not controlled, then again if there are no cardiovascular risk factors, again after lifestyle modification and metformin, SGLT2 inhibitors should be added in the treatment, and if the person is obese, then GLP-1 should be our choice. But if there are risk factors for cardiac or renal complications, then apart GLP-1s should be added. So if I summarize that GLP-1 and SGLT2 inhibitors or combination therapies nowadays are becoming a standard of treatment if the glycemia is high. Again, the guidelines by American Association of Clinical Endocrinologists, they also say that if the patient's HbA1c level is high, or problems of access are caused, then the preferred drug of choice is again either GLP-1 or SGLT2 inhibitors. But if the HbA1c is still uncontrolled, if the HbA1c still is high, more than 7.5, we must start combination therapies. Starting with either 2 agents or even more than 2 agents would be our basic approach in managing these patients with high levels of glycemia. So what our patients, they expect, they always expect that please Dr. Saab give us one single tablet that will completely cure me from diabetes. And they always expect that there should be a short-term treatment with lifelong cure. Now, unfortunately, this is not possible in Pakistan and all around the world, because we know that diabetes is a lifelong disease. So there is no magic pill, but we can make the life of these patients much more easier by giving them a single pill with 3 drugs that can meet our demands of glycemia, cardiovascular protection, as well as renal protection. And this fixed dose combination offers superior efficacy, improved compliance, and reduced pill burden. And this is the ideal triple combination that we are discussing today, is the combination of SGLT2 inhibitors, DPP4 inhibitors, and metformin. Now, metformin we know is a drug of choice for every patient of diabetes, type 2 diabetes, whether newly diagnosed or old diabetic patient, except when there are certain contraindications. We know that metformin is mainly acting on liver by decreasing glycogenolysis and gluconeogenesis, and it's also acting on skeletal muscle by increasing insulin-mediated glucose uptake and increased glycogenolysis. And not only this glucose-lowering effects, but metformin may have also potential effects on cardiovascular system by improving serum lipid profile levels.
SGLT2 inhibitors have changed the whole scenario of diabetes management. I call it as a paradigm shift drug in the management of diabetes, and it's mainly acting on the kidneys by blocking SGLT2 inhibitors in the proximal convoluted tubule. So we have three different mechanisms of fixed dose combinations in a single pill. Like on the one hand, we are increasing glucose excretion by giving empagliflozin as SGLT2 inhibitor. On the other hand, we are increasing insulin secretion by giving linagliptin, a DPP4 enzyme inhibitor, which increases the concentration of activating hormones and stimulating the release of insulin and decreasing levels of glucagon in circulation. And the third one is insulin resistance, and metformin is well known for its insulin resistance effects. I like to share a landmark trial of empiric outcome. In fact, it was the first trial on the empagliflozin or SGLT2 drug presented. And this is the initial trial that changed the overall shift of management of diabetes from glycemia control to cardiovascular risk factor reduction. And this trial it showed that there was lots of primary outcome benefits seen in terms of three-point major cardiovascular events, in terms of cardiovascular death, non-fatal MI, and non-fatal stroke. And in the conclusion of this trial, it was stated that empagliflozin is superior to placebo in improving glycemic control and reducing cardiovascular events in patients with type 2 diabetes and established cardiovascular disease, including mortality benefits. The other trial that I would like to share today is EMPA-Kidney trial and a meta-analysis of major trials of SGLT2 inhibitors. And the main purpose of doing these trials was to see the effects of SGLT2 on cardiovascular disease, progression of kidney disease, and need for hospitalization with chronic kidney disease. This EMPA-Kidney trial that showed that there was reduced progression of kidney disease or cardiovascular disease related deaths by 28%. And it also showed that reduced the need of hospitalization by 14%, which was a significant number. And the meta-analysis that we are talking today has shown also significant benefits in terms of cardiovascular death or hospitalization related to heart failures. This is the data that I will be sharing with you today about the triple axle study. It's a multi-center randomized trial. It's the first randomized control trial to investigate the long-term efficacy and safety of an initial combination therapy which consisted of three different oral anti-diabetic drugs, including metformin, SGLT2 inhibitors, and DPP4 inhibitors, compared with conventional stepwise add-on strategy in newly diagnosed drug-naive patients with type 2 diabetes mellitus. And as you can see that the primary outcomes were achieved in this study. The primary outcome was to see the levels of HbA1c reduction to less than 6.5% at week 104. And you can also see that this was achieved, HbA1c reduction was achieved without any added adverse events. There were routine adverse events of the drugs, otherwise there was no any other adverse effects even at week 56 or at week 104. The initial combination regime consisted of three different orally administered drugs that did not result in hypoglycemia or weight gain, which contributed to positive results in terms of primary outcome. Although the glycemic efficacy of each drug was modest, the combination of these drugs resulted in a 2-year durable glycemic efficacy with greater than 2.5% reduction in HbA1c levels from baseline. The overall results of this study suggest a novel strategy for initial combination therapy in newly diagnosed type 2 diabetic patients. So in conclusion, ladies and gentlemen, globally, poor glycemic control is common in people with type 2 diabetes, and improving glycemic control remains an unmet need and a key diabetes care priority. Early and intensive glycemic control in type 2 diabetes not only reduces micro and macrovascular complications, but also has a legacy effect that lower risk for decades.
and intensive multifactorial risk management, including blood glucose, blood pressure, and lipids, decreases long-term cardiorenal events and overall mortality. Initiating therapy should be personalized based on different individual characteristics, comorbidities, and shared decision-making with lifestyle interventions as essential components. An initial combination therapy may increase durability of glycemic control compared with stepwise addition of blood glucose lowering therapies. Thank you very much.